Chapter 39, Lower Respiratory Disorders. When discussing the respiratory system, a major factor we need to consider is going to be lung compliance. And by this, we mean the lung volume based on the pressure in the alveoli, as well as the influencing factors of the stretch, the connective tissue, the surface tension within the alveoli. Also, the patient's control of their respirations, such as oxygen, carbon dioxide, be it maintaining that balance where the patient is able to take in adequate amounts of oxygen while expelling that waste product, carbon dioxide. And that's going to become much more important, especially as we start talking in med surge about arterial blood gases and acidity. Your first major condition is going to be asthma. And this is an inflammatory disorder of the airway walls associated with obstruction. Could have triggers, everything from stress, allergens, pollutants, smoke, dust. And these symptoms are going to range from dyspnea, mucus secretions. Wheezing is going to be that hallmark sign of asthma. And you got to think about it from a written test standpoint. How would ATI, how would NCLEX describe wheezing to you? And it's going to be high pitched sounds within the lower airways. In the case of bronchial asthma, allergens attach to mast cells and basophils and stimulate a inflammatory cascade that results in that inflammation and that narrowing of the airway. Signs and symptoms would be everything from bronchospasm to wheezing, dyspnea, and mucus. In the case of chronic bronchitis, bronchial inflammation and excessive mucus secretions lead to an airway obstruction. It can be caused by everything from smoking, chronic lung infections, and results in a productive cough, hypoxemia, rhonchi, hypercapnia, and respiratory acidosis. Bronchiectasis. This is an abnormal dilation of the bronchi and bronchioles. In this case, the bronchioles become obstructed by the breakdown of the epithelium and tissue fibrosis that results. The causes are going to be everything from frequent infections to that chronic inflammation. Emphysema. This is a chronic progressive lung disease that results in the terminal bronchioles becoming plugged with mucus, leading to a loss in their fiber and elastin networks. In this case, the alveolar walls are destroyed and air becomes trapped in these enlarged, overexpanded alveoli, caused by everything from cigarette smoking, atmospheric contaminants, and a lack of alpha 1 antitrypsin protein. COPD. This is airway obstruction with an increased airway resistance or airflow to the lung tissue. Major causes would be everything from chronic bronchitis, bronchiectasis, emphysema, and asthma. Restrictive lung disease. These are pathophysiologic changes that result in a decrease in the total lung capacity due to everything from fluid accumulation or a loss of elasticity. Now, it's characterized by things like pulmonary edema, pulmonary fibrosis, lung tumors, or thoracic deformities, such as with scoliosis. To treat many of these, we need a bronchodilator. In this case, epinephrine is going to be the first one we discuss. And this works to restore circulation and increase that airway patency. Used for things like acute bronchospasms, asthma, anaphylaxis, nasal congestion, and status asthmaticus. It has side effects like including dizziness, tremors, hypertension, and angina, palpitations, tachycardia, and dysrhythmias. Albuterol. Keep in mind when we discuss this drug for ATI, albuterol is technically a trade name. So when it comes to ATI and NCLEX, they're going to give it a generic name, such as a short-acting beta agonist. And these all work to cause bronchodilation, a rapid onset of action. They have a longer duration of action and fewer side effects. Used particularly for things like asthma, acute bronchospasm, and it has side effects such as headache, rhinitis, excitability, tremors, palpitations, and tachycardia. And keep in mind when you're combining two respiratory inhaled medications, we're always going to give that albuterol first because that albuterol is going to have a more rapid effect, but it's also going to open up that airway for our secondary medication as well. Metoprolol. This is an inhaled administration preferred for long-term asthma treatment. Everything from asthma, COPD, and common side effects would be headache, dizziness, tremor, nausea, and again, tachycardia and angina. Next would be anticholinergics such as tiotropium. And this is a maintenance treatment for bronchospasms associated with COPD. It's administered by inhalation only, and common side effects would be everything from dry mouth, constipation, depression, insomnia, pharyngitis, sinusitis, arthralgia, and peripheral edema. Next would be theophylline. This works to relax the smooth muscle within the bronchi, and particularly used for asthma. It's going to have side effects, everything from dizziness and headache again to irritability, hypokalemia, seizures, tachycardia, palpitations, and dysrhythmias. Leukotriene receptor antagonists. These reduce the inflammatory process and decrease bronchoconstriction. Used for everything from asthma, prophylaxis for exercise induced bronchospasms, and common side effects dizziness, headache, confusion, depression, weakness, and infection. Glucocorticoids, steroids. These, again, inflammation. As soon as you see steroids, immediately be thinking inflammation. We're going to have the normal steroid side effects as well: throat irritation and hoarseness, but also hyperglycemia, hypertension, weakness, fluid retention, osteoporosis, and a risk for superinfections. When giving any bronchodilator, we want to assess for any wheezing, decreased breath sounds, cough, and sputum production. We also want to carefully monitor vital signs, provide adequate hydration, administer the medication at regular intervals around the clock to have that sustained therapeutic effect, and advise the patient about having asthmatic attacks to wear an identification bracelet or a medical alert tag should they become incapacitated, should they have a emergency out in public. We can have a clue of how to help them. When giving leukotriene receptor antagonists, we're obviously going to focus on oxygenation anytime we're giving any of these respiratory meds. We also want to assess for any wheezing, decreased breath sounds, sputum production, assess their hydration levels, and keep a careful eye out for any dyspnea or airway obstruction. Again, monitor those respirations for rate, depth, rhythm. We want to see their patient's work, their effort. Are they struggling to breathe? Are they breathing normally with minimal effort? We also want to observe lips and fingernails for any cyanosis. Monitor liver function tests periodically. Advise the patient to quit smoking, obviously, and also advise the patient to have frequent or severe asthma attacks to, again, wear that identification bracelet. Cromolyn. This inhibits histamine release, preventing asthmatic attacks. Used for bronchial asthma prophylaxis. We would be looking for common side effects such as cough, postnasal drip, and the dangerous effect of rebound bronchospasm. Drug therapy for asthma is going to be based on the severity. In the case of chronic asthma, we're going to be controlled with long-term medications, with quick relief used for acute emergencies. The long-term program may vary according to the symptoms of the asthma, its severity, and also what the patient reacts most positively to. For young children, cromolyn is used to treat the inflammatory effects, while oral glucocorticoids for young children to control those moderate to severe asthmatic states. On the other end of the spectrum, in case of the elderly, we're going to use careful consideration of drug selection and dosage due to the increased risk for adverse effects. For our first practice question, the patient has just received a nebulizer treatment of metoprolol. It's most important for the nurse to assess the patient for the development of which side effects or adverse effects. That'd be A, tremors, B, bradycardia, C, hyperkalemia, or D, constipation. And that answer is going to be A, tremors, as tachycardia is a potential adverse effect, not bradycardia. Practice question 2. Which of the following is best to teach a patient with chronic obstructive pulmonary disease about the use of the medication albuterol? A, that it mobilizes respiratory secretions. B, that it decreases the cough response. C, it increases the work of breathing. Or D, it dilates the bronchioles long term. That answer is D, that it dilates the bronchioles long term. Question 3. Which of the following should the nurse teach regarding the use of cromolyn in the treatment of asthma? That'd be A, that it assists in opening narrowed airways. B, it suppresses the release of histamine and other mediators from the mast cells. C, it loosens the mucus from the airways. Or D, it prevents serious complications from bacterial infections. And that answer is going to be B, that it suppresses the release of histamine and other mediators from the mast cells. Question 4. A patient is using a glucocorticoid inhaler. The patient asks the nurse why he has to rinse his mouth out after using the glucocorticoid inhaler. Which of the following is the best response from the nurse? That be A, avoid mucous membrane breakdown, B, increase hydration of the oral mucosa, C, decrease risk of infection, or D, slow the development of cavities. And that answer will be C, decrease the risk of infection. Question 5. A home care nurse is visiting a patient with asthma who suddenly experiences an acute asthma attack. Which drug should the nurse prepare to administer? That be A, ciferculast, B, cromolyn, C, metaproterenol, or D, Zolutin. And that answer will be C, metaproterenol. For our final question, a patient with chronic bronchitis is admitted to the healthcare facility for treatment of a bacterial respiratory infection. Which antimicrobial will most likely be ordered for the patient? That be A, Zeldane, B, amphotericin B, C, acyclovir, or D, trimethoprim sulfamethoxazole. And that answer is going to be D, trimethoprim sulfamethoxazole. Say that 3 times fast. But anyway, that's all we got for this chapter. I'll see you in the next slides.